Thank you, everybody. And thank you, Dr. Herx and Dr. Quello, my esteemed colleagues who are very difficult to follow. So speaking of safeguards for the vulnerable, the first thing I would want to clarify is the best safeguard for someone who's vulnerable is a person who cares for them. There are no rules or policies that will ever protect a person like someone who cares deeply for a person. And in order to protect every person who's tempted to consider euthanasia or suicide, is a physician who's willing to meet them in the dark and low moments of their life. And one provocative way that I've used to say this is that as physicians, we should be willing to go to hell with our patients and then provide them with a life-saving hand and lift them back out into the light. So like I was saying, to protect the vulnerable and to protect conscience, the best thing to do is to protect those people who are willing to lift people out of dark places and who are willing to do something that will not harm their patients. So a question we could ask is, who are the vulnerable? I would say that all of us are vulnerable at various times in our lives, but at some point, we're all going to face death, which is an ultimate vulnerability for all of us. Others will be vulnerable because of disability, others because of mental health. And some of us in times like this are vulnerable because we feel misunderstood or alone, especially in these times of isolation. So there's no shortage of vulnerability in our world. And there's a profound meaning in the fact that there's lots of vulnerability and lots of suffering that we need to alleviate. And as a society, I would say that we need to relearn how to be vulnerable and how to love the vulnerable and depend on each other rather than being self-sufficient. We also need to learn how to suffer again and how to find new ways to relieve suffering. And I would say, this could be a moment of great creativity to find new ways of caring, but instead what our government is pushing is new ways of disposing of people who suffer. And rather than an approach where we cover people's suffering, literally to palliate people, we're abandoning patients because we're giving up the creative process of finding new solutions for them. And believe me, I get it that it's not always easy to have clear-cut solutions for people suffering. I have patients in my nursing home who are on several medications for pain, and they never have full pain relief. But I still visit them weekly and we try to find ways of lifting their burdens. One of my gals who has intractable pain constantly has a 6 out of 10 pain level of pain on a 0 to 10 scale. And the things she likes are Cheerios. So I made sure that the dietary staff give her 2 bowls of Cheerios every morning, because it helps her with her pain. And the big thing there, as far as a doctor who cares, is helping to shoulder burdens to make them a little bit lighter. It doesn't mean that we can always eliminate them. But as you all know, with suffering you've had personally, it's always easier to bear suffering when we can shoulder them with other people's help. We shouldn't be surprised when people ask about ending their lives. Many of us who are Christian know somebody who asked not for his life. And, in the Garden of Gethsemane, when Jesus says, let this cup pass from me, he was asking for a suffering to pass by him. So we shouldn't be surprised even somebody as strong as Jesus Christ asks for relief of suffering, right? And we should be willing to go to those dark places with people. And before euthanasia was legalized, the whole medical community was finding different solutions for people who felt like the only solution was ending their life. And now it seems there are very few of us who are willing to search for different solutions. And at this time in our history, we really need to stand courageously to continue to do this as healthcare providers, as families. And just because euthanasia is legal does not mean that people need to be abandoned to euthanasia, which is not a form of care. There's sometimes confusion about what some have talked about a term that is sometimes used of withdrawing care. But the reality is we never withdraw care from anybody. We sometimes withdraw interventions that are no longer helpful, but we never withdraw care for people, which means effective pain control, addressing distressing symptoms that people have, making sure that families are present. You know, at my nursing home, I've always insisted that families come and are present at the end of people's lives, making sure that they have the appropriate PPE so they can be together in their last moments. And people can detect a caring doctor and a caring institution, which is why some institutions in this country have not had euthanasia requests. And I really, truly believe that one person at a time, we should provide such excellent care that we make euthanasia unthinkable, even though it's legal. I also want to address the physician-patient relationship. The opportunity to protect vulnerable patients still exists in the physician-patient relationship, and it is imperative that we protect that sacred place of trust. When we come with our vulnerabilities to our own physicians, we shouldn't hide our problems. As one person once put it, we should show the pus of our wounds to the doctor, otherwise the doctor won't know what to do to heal it. So in that vulnerability, in that vulnerable moment, we need to ensure that the politicians and elite of our day are not forcing the hands of doctors to give up on tough cases and jump to euthanasia rather than trying to dig for deeper caring solutions. And when talking about protecting conscience, we protect the physician-patient relationship of trust when we do that. Physicians, being in a position of authority, don't want to lord over their patients with their opinions. They want to be a resource to educate their patients who are equal partners in advancing their care. And to be sure, there are times when patients and physicians disagree with each other, but rarely does that ever come to a point of conflict. There are rare times even when a patient of mine has chosen to transfer to another physician because of a difference of opinion or because I wasn't a good fit for them. But the majority of the time, patients who disagree with my advice are willing to discuss it in a friendly manner and find alternative solutions. However, our current federal government, Supreme Court, and many provincial medical colleges are setting up caricatures of people, physicians like ourselves, who don't want to be involved in euthanasia and make it seem, but the reality is that because we don't see it as a compassionate option for our patients, we just want to remove ourselves when patients go down this road. The relationship between the vulnerable patient and the caring physician educator is a place where mutual freedom and trust needs to be built up over time. If a physician feels that he or she will be disciplined if they don't toe the party line, they won't have the freedom to be open and honest in their discussions with their patients. And so again, that relationship needs protection, and C7 has done nothing to protect that intimate relationship between patient and physician in their vulnerable moments. Patients can no longer count on our medical system to discourage them from falling into despair and thinking their lives aren't worth living. Instead, physicians like us who want to accompany patients in those difficult and dark places might be punished if we don't endorse and move people down the path of made without question. Of this is that of patients. And both Dr. Herx and Dr. Coelho mentioned the issue of waiting times. So one dimension that you all know about when it comes to vulnerability is that sometimes it just takes time to heal. People who have had miscarriages or have lost a loved one know that sometimes the only thing that will help them heal is time. And without the time accompanied, that time that's needed, accompanied by a caring physician, it's no wonder that people can fall into despair. And it's a symptom of the fundamental impatience of our culture that we're not giving people enough time. And as soon as someone requests death, the clock starts ticking. And there's nothing creative about that. That's abandonment of the creative process of care. People with disabilities, especially, as Dr. Coelho pointed out, the study on spinal cord injuries, it can take time, up to 2 years, for someone to really accept the reality of their condition. And Bill C7 would instead give people 90 days which is an impossible countdown for them to reach because there are so many specialists who you can't even get to see within 90 days. And so in Canada, it's easier to die than to live. And like Dr. Hertz pointed out about the standard of care, the standard of care is going to be killed in Canada with this bill. The next thing relates to diversity. It's pathologic in our society to suggest that some diversity is acceptable, but other diversity is not. So, you know, it would seem that now the diversity of opinions in the medical profession on this topic specifically has now turned into uniformity or groupthink. In 5 short years, those of us who are opposed to euthanasia have become a persecuted minority to be left with little protections for participating in the euthanasia process. And when we are strongly opposed to each other's opinions, this type of peaceful disagreement should still exist in our society, but to do that, everyone's conscience has to be respected. Everybody in medicine, every single doctor has their own lines in the sand and different opinions. Transferring care is totally appropriate when there's not a good fit, say, between a physician and their patient. And disagreements between the two should not be seen as a rights competition or even a conflict. And the government and medical colleges should not micromanage the doctor-patient relationship and leave individuals' freedom intact instead, so that they can choose the fit that's right for them. A point about access. Protecting the physician-patient relationship means that questions of access should not enter this question. Many politicians, ethicists, and observers are suggesting that access is an essential part of the physician-patient relationship, when in reality, access is something guaranteed by the provincial healthcare system. In 2018, Dr. Diane Kelsall, who's with the Canadian Medical Association Journal, wrote, "The responsibility to ensure access to MAID does not rest with the individual physician, but with society. It is the role of provinces to provide an accessible system that does not require referral. If a particular physician did not think it were good for a patient to pursue a particular course of action, they should not be forced to follow through, but offer alternatives of care. This could include a second opinion, a transfer of care to another doctor, but it should not include a forced referral for something a physician feels is harmful for their patient." Another editor from CMAJ, John Fletcher, wrote in 2015, just prior to legalization of MAID, that Canadian society may soon allow some doctors to redefine their role, but this should not compel the majority of physicians who are not comfortable with this to abandon their convictions. Conscience is not a matter of taste or personal preference. It's a deeply held conviction which prevents us from providing or helping in the process to pursue certain things that are harmful to patients. One final point on autonomy, and I know Dr. Coelho brought this up as well. It is ironic that we're attempting to save all lives, lives at all costs with COVID-19, and protecting vulnerable and elderly nursing homes is but Bill C-7, on the other hand, is prioritizing their deaths. It blurs the lines and makes it difficult for people who are vulnerable and suffering to choose life, when the easier route seems to be to choose death. We can see even with COVID that our high esteem of personal autonomy is that autonomy does not trump all other considerations in medicine. In the COVID era, we see also the creativity and development of vaccines, and that can even revolutionize other areas of vaccine development. If we give up the creative process with those who suffer, we lose the chance to find those new ways of caring. Bill C-7 would make Canada the most eugenic country in the world, putting disabled people and elderly on death row. And there are subtle pressures that both Dr. Hertz and Dr. Coelho brought up that will make it make people want to end their lives early rather than giving them the care that they need. People with disabilities are especially vulnerable in Bill C-7, and they deserve special care and attention. Our general rule should be the more vulnerable people should deserve protection in special ways, and not be put on death row. So finally, I'd like to really just emphasize that conscience protection is not primarily about protecting myself and my own self-interest, but about protecting my patients. Rather than being an attitude that's focused on myself, the conscience of a physician is a source of insight for a patient who is trying to seek out their own best interest. And in this sense, the pursuit of medicine in the best interest of the patient requires that physicians practice with integrity and not check their moral compass at the door. The therapeutic relationship of trust that I brought up between a patient and a physician is a place where mutual freedom and mutual trust should be built. Physicians ought to attempt to get into their patient's worldview to understand their needs and honestly admit when there's difference of opinion, emphasizing patients' complete freedom. The patient-physician encounter should remain one of the safest places in society, a medical home. Sometimes that safe place involves choosing a physician who is like-minded, and for that we need to respect the diversity of views that Canadians hold. And we need to feel at home with our physicians, and that means we have to have different types of homes in the pluralistic society we live in. The medical home should be a place of creativity where we work together as physicians and patients to improve lives. And again, I would say that every suffering person is an opportunity to find new ways of caring. Thanks so much.